And welcome to today's webinar, Why Certain Standardization Kills Hospital Operating Efficiency. On behalf of Becker's Healthcare, thank you so much for joining us today. Before we begin, I will walk through a few quick housekeeping instructions. First, we will begin today's webinar with a panel presentation, and you'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. If at any time you do not see your slides moving or have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box at any time. We're here to help. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. With that, I am so pleased to welcome today's panel, Dr. Thomas Feo, CEO and co-founder of Healthcare Control Systems, and Luke Doyle, VP of Operations and Sales for Healthcare Control Systems. Luke and Tom, thank you so much for being here. Luke, I'll go ahead and toss the floor over to you to begin our discussion today.
Great. Thank you, Claire. Appreciate it. And thank you again, Tom, as well for your time. This is sort of a back by popular demand. We've done one of these before, but we had such a good turnout and a lot of great questions, even some we weren't able to get to. So I'm glad we're able to kind of redo this again and get some more people involved. I think to set this up, Tom, what I'd like to do is just introduce you briefly, just your educational background and history there, because I think it leads very much into what we're going to be talking about today and just in terms of your background. So as I was going through this, we've got your bachelor's degree and 4 advanced degrees, which is in operations research. So it's incredible. So actually 3 degrees from the University of Pennsylvania, starting out with your Bachelor of Science in Electrical Engineering, and then 2 masters, one from Wharton in finance, and then 1 master's in computer science. And then you moved on to Cal Berkeley for another master's, this time in operations research. And then finally your doctorate, also from Cal Berkeley in operations research. And then you moved on to your teaching career, also in operations research, starting at Cal Berkeley, then at the University of North Carolina in Chapel Hill, and finally as an endowed professor at the University of Texas in Austin, again, all in operational research. And again, the great educational background in this area, which leads into what we're going to talk about today. But I think as a lot of professors, they do a great job teaching, they know a lot, but then don't always practice what they preach. And you actually did that beginning in the 1980s. You kind of got out of academia and went right into applying your knowledge in operations research. Maybe we could talk a little bit about that background and then dive into how it applies into the healthcare environment today.
Sure, Luke, thank you. First of all, we'll welcome everybody and wanted to thank Becker's for this opportunity. We did start quite a while ago in manufacturing back in the 1980s. We were put together the first floor control system for Texas Instruments, and it was really these minute-by-minute coordination systems that really kind of pulled the entire factory floor together. In the 1990s, we migrated from manufacturing, which was a very crowded space. Everybody was doing just-in-time manufacturing and all of the other, sort of floor control systems. We migrated into transportation centers and really hit a grand slam home run. We ended up capturing about 70 to 80% of the market share across the US, Canada, and Australia. And we were very proud of the fact that the US Department of Transportation awarded us for most improving the competitiveness of the entire US transportation industry. We took all of that intellectual property that we had put together and we started applying it back about 10, 15 years ago to healthcare. And we basically started developing the same concepts that were in manufacturing, that were in transportation. We started developing them for hospitals, for large medical centers. And basically, these are minute-by-minute coordination systems. And the whole idea here is that you're trying to pull together all these different people that are trying to get through their shifts and trying to get all their work done, and you're coordinating them so that they can be efficient and they don't have to sit there and figure out how to wait for somebody here and wait for somebody there. Today, we're actually our system actually runs in the top 4 healthcare systems in the US, HCA, Ascension, Common Spirit, and the VA. So we've done quite a bit in the last 10 or so years, both in the US and in Europe. And so what we're going to talk about today is these minute-by-minute coordination systems and how different they are than a lot of the other IT systems that people are very familiar with. So really, let me just start, Luke, by just describing what the problem is. It takes a huge amount of human touches to bring a patient safely into an OR. And every morning, hospitals start fresh with a great set of well-trained staff with great planning and scheduling. They start with everything all prepped and ready to go. But unfortunately, within the first few minutes of every day, they run into all these disruptions that nobody anticipated. You have a patient that reveals an allergy at the last minute. You have a patient that's eaten breakfast and now that case has to be canceled. You have sterile processing that can't find a tray, or you have a surgeon that you can't find or is running late. All of these disruptions that happen literally at the last minute basically disrupt your beautifully planned schedule, your well-trained staff, and everything else. And it really falls upon your frontline staff to try to figure out what to do at 6:47 in the morning when these things just pop up out of nowhere. So what you're really trying to do, the solution that you're trying to address here, is one where you're basically looking for some way to help your staff coordinate through all of this, but not just your local staff, not just the staff, let's say, in your cath lab or in your ORs, but across all the different silos that have to be there and have to be available in order for the system to work well and for you to be able to get your cases off on time. So what this really is, the solution really is this sort of air traffic control that exists in all these other industries, whether it be manufacturing or in transportation, and now it's been introduced into hospitals. It's this ability to have all of your frontline staff be able to, on the fly, execute their job in a way that is coordinated with everybody else in the facility. And so what it really does is it really supports your frontline staff here and now so they can remain effective and productive. So that kind of gives you an idea of generally what we do and how we approach it. We can get into some more detail, but let's right now try to get some examples like we did the last time from folks that are listening in about how disruptions to their schedules really derail the beginning of their day. And those disruptions continue throughout the day and basically keep them from being as productive as they should be.
Yeah.
So let's see if we get some questions in, and then we'll address those, and that'll make everything a lot clearer for our general audience.
Yeah. So while we're waiting, we're getting some through the chat now, but while we're waiting for those to collect, Tom, let's talk a little bit about the title of this presentation, because we talked about how standardization can have an impact on efficiency and maybe even kill efficiency in certain aspects. So can you talk just a little bit about that and give some examples as we're letting some other questions materialize here?
Sure. No, absolutely. So the reason that the title of this talk is how standardization can kill your frontline efficiency is really, it has to do with the fact that you're really looking to support people throughout their disruptions during their day. You're really looking to support people at a very local level, very frontline staff. Standardization is absolutely wonderful in hospitals when it comes to accounting systems, when it comes to how you're doing your billing, how you're doing your regulatory reporting. Standardization is also wonderful when it comes to clinical practices, especially infection control. There's a very standard way that you're going to be doing, catheterization of a patient. And those standardized practices and procedures and systems are wonderful. But where things don't so much work for standardization is when you're talking about a specific facility and somebody tells you that you have to standardize the way, let's say, you interact with sterile processing. Well, the reality is in some facilities, sterile processing is across the street in another building on campus. In other places, it's literally on the same floor as your ORs. So the thing is, you can't have a standard practice for how you're going to approach something like sterile processing, or how you're going to approach something like your interactions with other out of departments like blood bank or pharmacy, or even how you're going to deal with, let's say, anesthesia. Do you have a dedicated anesthesia group in one facility where in another facility you're sharing anesthesia resources across many, many different departments? So the idea here is that when you look at something like air traffic control, minute-by-minute coordination systems like what we're talking about today, standardization doesn't make any sense. You have to have that system be completely and totally adopted and characterized by what your physical reality is. Whether it's your physical plant or whether it's even, a surgeon or a set of surgeons that want things a certain way. You just have to make sure that we have a distinction here between what types of things can be standardized, especially at the corporate level and at the clinical level, and then sort of this execution layer where you're really looking at having the support for your staff given the reality that they have to live in, which is their physical plant and the types of interactions they have with their different out of departments and also with their surgeon and anesthesia communities.
So Tom, you mentioned surgeons appropriately, because one of our first questions that came in here was related to delays caused by just simply surgeons not showing up on time and being part of the process.
Yeah, so I think that's a great example, one where what you're looking at there is a surgeon that, let's say, is habitually late, and how do you address that? Well, what typically happens when you don't have a minute-by-minute coordination system is the surgeon shows up whenever he or she wants to show up, and now all of a sudden there's a lot of finger pointing. Well, was the room really clean? Was the trays in the room? Did we have all the equipment in there? Was the patient pre-op properly and available? All of these questions come up. When you have a minute-by-minute coordination system in there, all of that is transparent. You know exactly when the surgeon showed up. You know exactly when the room was cleaned. You know exactly when the trays were there. So now everything becomes obvious. So if somebody is showing up late, and we've had this happen in many of our hospitals where the surgeon literally shows up 15, 20 minutes late, they look at the board and they go, oh, shoot, everyone's waiting for me again. It's clear. You've really built an environment now where there's nowhere to hide. It becomes super clear that everything is now exactly the way you can see it on the board at the time that it's happening. And when you get that, what's really interesting is you end up getting a change in attitude among everybody. All of a sudden, this becomes a team effort, whether it's across different silos in these out of departments, whether it's with surgeons or anesthesia, or even when it's with patient families. Everybody feels like they're on the same page. They know exactly what's going on, and they're able to now address these disruptions. So let's say the surgeon is late. Everyone sees the surgeon's late. Maybe this means that you can change something in your schedule right now to not only accommodate the surgeon coming in late, but also make sure that your team doesn't go idle for another half hour.
So we have another question, opposite of the idle question, which is we've got delays now that have caused problems in the day, and we're now looking at the shift change and when staff can possibly go home. So are we going to hit the mark and go out at shift change, or are we going to have delays? So again, that's another question that's coming in terms of that.
So you certainly start the beginning of your day with a fixed schedule, and it says, geez, everyone's going to be going home at 3 o'clock at shift change and all this. You hit these disruptions, you have these cancellations, you have emergent cases coming in. The thing basically looks a little bit like a mess by noon, or even by 10 a.m. The rest of your day is looking very different than what you had, that came out of, let's say, your AI scheduling module the day before. But at 10 o'clock, what you do have is you do have a board now that's showing you exactly how everything's supposed to be transpiring going forward, given all these disruptions that have been put in there. So you can see at shift change at 3 o'clock, you're still right now planning on having 3 other rooms still running. So now you can plan on staff, and you can plan on what staff needs to be on callback, what staff can go home. You can start working through your day, and you can start giving people an idea of what, the next 3 or 4 hours is going to look like, a lot more precisely than you would if you were still going off that piece of paper that told you what the schedule was supposed to be like, at 6 a.m. in the morning.
We had another question about managing, we're sharing resources across the facility, but procedure rooms that are not managed by this individual. So maybe sort of those out-of-department procedures, but yet you're sharing resources back and forth, and that can cause a lot of confusion and issues.
So let me answer the question. I think I understand where they're coming from. So one of the other things that we talked about is scope here. A lot of times, a lot of IT systems, a lot of initiatives really focus on, let's say, just one department. The thing with air traffic control, with what we're doing here with OR control and with these minute-by-minute coordination systems, is they have to span across every department that can delay your procedure. And so I think what this individual is saying is that, geez, I'm in control of, let's say, my OR, but I'm not in control of, let's say, sterile processing. I'm not in control of my blood bank. I'm not in control of my anesthesia group because, yes, they do a lot of cases in my department, but they also do cases over in cath and endo and other areas. So the idea here is that when you have a air traffic control system, you can't just control one runway. That would be a disaster. And just like with the systems in hospitals, you have to have a system that spans across all of these different departments. So that individual now can see what's going on in all of these other departments, just like those departments can see what's going on in the OR. And now you have what ends up becoming a team building exercise here, or a team building system, because now people can see, oh, look, yes, I need anesthesia resources for this case, but they just got assigned over here. So now I'm going to have a 15-minute delay here. I'm going to have a 20-minute delay because some case carts aren't available quite yet. But look, my blood is ready. My pharmacy's ready. My patients are ready. One surgeon is running late. Now, all of a sudden, it gives me the ability to be sort of a Monday morning quarterback and say, okay, now I can figure out how I'm going to rearrange things in the next 15, 20 minutes so I can keep everybody busy and productive.
Yeah.
Otherwise, what's happening in the past is you get all these people that basically say, I can't control what's going on. I haven't gotten a phone call. I haven't gotten indication of whether this is going to be available or not available. So that becomes very difficult for people to work through that. And the tendency is for them not to do anything, to just sit tight until they hear.
We had another question. This is you're covering around this question, but I thought I would just touch on it since it came in. But it was referring to a patient that's showing up late. Before we had the surgeon showing up late, but the patient showing up late. And now you have two patients kind of requiring the same procedures, the same process. And you've got to, so it kind of relates, I think, to your air traffic control in terms of how you manage that, right? These are all disruptions you weren't counting on, whether they be surgeon or patient or outside department, correct?
Yeah, no, patient coming in late is a perfect example. So now you can see it on the board. You can see, okay, this patient just showed up. We're going to go ahead and pre-op this patient. This is about how long that's going to take. Maybe we had that patient was supposed to start literally in 2 minutes and they're not going to be ready. So maybe we can move this other case where the patient showed up a little early or has been pre-opt already. We can move that case into that slot, take advantage of that team being available and doing that case first, and then position that other patient, 45 minutes to an hour from now when another slot opens up. The whole idea is to be as flexible as possible, but you need information to be flexible, and you need the ability, if you make these kinds of changes, for a system to be able to communicate that across everybody, not just with your circulator, not just with that team, but everybody. Now that includes the system ties all of this back into your breaks and lunches. It ties it all back into your assignment of your circulators and your scrub techs and your anesthesiologists for each one of these cases. And this isn't just in one department or one group. This goes across hospitals. And in fact, in some of our implementations, we go across the metropolitan area. So now you have anesthesia actually looking at this and reassigning resources because one hospital had a bunch of emergent cases and they need to take an anesthesiologist from one location and move them a few miles away to a sister facility where they can actually do the cases there. Yeah, go ahead.
Yeah, no, I mean, I'm kind of trying to pull together a number of questions coming in and lump these together. So, we've got a question about, how do you manage across, and you've been touching on this a little bit again with air traffic control and I think the global visibility, but how do you manage multiple issues that are coming in at the same time, right? Because you've got multiple things happening at once that could be problematic. And the same thing is you could have a case where you've got a delay, but you really can't do anything about it, right? I mean, you've got a limited amount of time and ability, but again, that global visibility at least keeps everyone informed as to what is.
I mean, the idea is the biggest, the 500-pound gorilla here is not to have a bunch of your staff and teams sitting idle for a long period of time because something got delayed or something got canceled. And now there is no way that there's anybody on the very frontline staff that can, first of all, identify that immediately, push it into a context where everybody else sees it, and then somebody like a board runner or an OR manager or director gets and says, okay, I'm going to rearrange these two things here so that this team isn't idle anymore.
And so this
isn't a godsend in the sense that, yes, things happen and you are going to have delays and you are going to, but the question is, how much are those delays, are you going to be able to mitigate the long-term effect of those delays? Are you going to have a delay at 8 in the morning and then have that constantly be bugging you throughout the rest of the day to the point where now you're having all these callbacks at 3 o'clock and you have a bunch of canceled cases and everything else?
So, and you'll touch on this a little bit, but you have visibility on smartphones, tablets across the facility. So no matter whether you're on site, off site, or what, you have visibility in real time as to what's happening. And then also triggering some automated alerting so that you're not relying on having to pick the phone up, make phone calls, et cetera, to keep everyone up to speed as to all these changes and things that are happening, correct?
Yeah, so think of it like air traffic control. Air traffic control would be worthless if you weren't seamlessly communicating with all your pilots, whether the ones wanting to take off, the ones wanting to land, the ones wanting to navigate the ground to get to their gate. I mean, this is literally air traffic control for a medical center. Yeah, go ahead.
So what have you seen sort of in the way hospitals have, in all the ways in which they've tried to address these things in the past? I mean, they have many opportunities and ways to do that. And I think we can touch upon how that has happened in terms of what hospitals are doing.
Yeah,
currently.
Most hospitals have put a tremendous amount of effort into what I would say best practices. So basically they've hired consultants or they've hired internal groups and they've tried to come up with best practices. And best practices are wonderful, but they still don't address what happens when we have all these disruptions that occur and derail you, and especially in the first few hours of your day. Hospitals have also put a tremendous amount of time and effort into their electronic medical record systems. They've done a tremendous job in the last 10, 15 years in terms of really good schedules, especially most recently using artificial intelligence. And certainly their training is ongoing. And as I said, and to many CEOs, look, your staff is very well trained. You have good schedules at the beginning of the day. You have a very good EMR in many, many regards. And you have lots of good best practices that you've instituted. What we're really talking about is something completely different. We're really talking about how do you execute on all of that? You've made all these investments. How do you take all those investments and make sure that they turn into something where you actually get the productivity and efficiency throughout everybody's shift? So you think about these investments, and this is a great slide, by the way. Thank you for bringing this up. So you have all these major investments that you've put all this time and energy into. All of these are inputs into an execution system, like OR control, this minute-by-minute coordination system. It's like you've invested in these great schedules, you've invested in let's say, real-time location tracking, you've invested in great personnel systems and consultants, and now you're taking all of that investment and you're putting it into an execution layer, which is this real-time, basically flight control system. And what's coming out of it is this coordination across your entire medical center. So if you look at on the right-hand side of the slide, what you're really doing is you're saying, look, we need to tie together what's going on this very moment in endo, in transportation, in housekeeping, in the floor units, in PACU, with the anesthesiologists. There's nothing like that today. Basically, the way you're doing that tie together today in almost all hospitals that don't have these systems is with phone calls or running down the hall and trying to find somebody. So the fact is, if you were trying to run a busy airport that way, that would be a disaster. I mean, your throughput at the airport would be so slow. You'd be able to maybe take off and land a plane every 5 minutes, as opposed to now where they're coming in every 15 seconds.
Mm-hmm. Yeah, right. So I guess, and continue to ask questions. We get more questions coming through the chat, so we want to continue to do that, and we'll save some time at the end as well. Can we talk just a little bit then about the results? Right, we've got the layout and what we've done, leveraging these investments. So if we could talk a little bit about sort of what comes of all this.
Yeah. So basically, what we talked about a second ago, which is you're constantly refining your best practices. You're constantly refining your scheduling. You're applying artificial intelligence and coming up with even better and better schedules. You're putting in more and more resources into better training. And all of these are great initiatives, and hospitals have gotten benefits from these. But what we've seen over and over again is the benefits you're getting from all these initiatives, the cost of these initiatives, especially in terms of your staff time, it seems to be diminishing returns. You are getting benefit, and the benefits are somewhat substantial and measurable. But when you think about overlaying all of this with a flight control system, something that actually helps your entire staff across multiple silos in your organization coordinate minute by minute, now all of a sudden you're talking about a huge step function. And we saw that in manufacturing back in the 80s. We saw it in transportation in the 90s and in the noughts. And we certainly have seen it now in all of these hospitals that we've put these systems in. And that's probably why we're in the top 4 major systems in the US. Because this is something that once you put this type of system into an industry, and it doesn't matter whether it's manufacturing, transportation, or healthcare, you get this huge step function. Because now you're allowing your frontline staff, you're allowing that nurse that just found out that the patient ate. And this is a nurse that is fairly low down on the administrative level and in the hierarchy and all of this, but he or she just found out that the patient ate. What tool does that person have to be able to, first of all, immediately convey that without making a phone call, having everybody see that now the case has to be canceled, to be able to have everybody understand that there's an opportunity now to put other resources and reassign people on the fly at that very moment, so that you don't have a bunch of people sitting idle because something completely unexpected, like the patient announces that they had breakfast this morning, was completely off the radar screen literally 2 minutes ago. So this is why when you start looking at these results, you start realizing there's a lot of low-hanging fruit out there about how you can run a more coordinated and a much more efficient and productive manner. And it doesn't have to do with improving your best practices or improving your training or improving your schedules. It has everything to do with that execution layer in your hospital.
Mm-hmm. Tom, we've had some additional questions, different departments. You've touched on this a little bit. Maybe you can circle back. So managing the cath EP area, managing radiology, managing endoscopy. Not always do those departments report to a central OR director, sometimes others. But you mentioned this earlier. If you want to cover it again, just in terms of covering all of those areas, because they're all intertwined and interlinked, right? So.
Yeah, no, absolutely. And that's the whole point of these systems. That's really what we're getting at is, let's say you have a problem in your cath lab or in radiology. Let's say you have a patient that's supposed to go to radiology first prior to them then going over and having their procedure done. Well, that's a perfect example. If radiology is backed up, now your procedure is going to be delayed. So first of all, identifying that and having everybody understand that that is part of the process this morning that case has to go through radiology, and radiology is now showing that they're 45 minutes delayed. Do you really not want to know that right now and be able to address that 45-minute delay in one of your ORs and have at least the opportunity to address that and maybe change things around on the fly? And again, it's to people saying, well, maybe I don't have the time to change things. There isn't another case. That's fine. And that's certainly the reality of the day-to-day operations. But what we find is that at least some significant percentage of the time, you have the ability to address these things on the fly and actually keep your staff productive. And what that means at the end of the day is you have much less overtime. You have many more cases. You know, you're not canceling cases or delaying cases to the next day. And what you end up with is a case count now that is much higher than it would be otherwise. And in fact, maybe we could go into more of the results here and kind of show the impact that these systems really can have. So these are documented results from the hospitals themselves. These aren't things that, you know, came up in a marketing collateral, but you know, first of all, the first thing you realize is that if you're managing all these disruptions across all these departments, all of a sudden your ability to execute your first case on time goes way up. And in one of our facilities, we were actually able to go up to 94% on time start. And this isn't giving a 5-minute or a 15-minute leeway. This is, you have to start within 60 seconds of that 7:30 or 7 a.m. start time. Likewise, throughout your day, if you're coordinating your cleaning, you're coordinating your anesthesia consults, you're coordinating everything to do with your SPD trays and with you know, your blood bank and pharmacy and even your radiology, that maybe the patient has to visit radiology prior to coming into the OR. Now you start realizing that you can actually get your turn times under 20 minutes, even for complex cases. Likewise, what we've seen is because you're filling in all these holes throughout your day, you're not just saying, oh, geez, that case got canceled. Well, we can't figure out how to get something else in there, or it's too complicated, or too many phone calls, or too much disruption. We're just going to let that team sit idle for an hour, you know, waiting for the next case to be ready. Now, all of a sudden, you're backpacking things, and now what you realize is you get this incredible increase in your OR case volumes. And in one of our facilities, they documented that they were actually doing 41% more cases than during prime time than they were previously. So
Tom,
again, all these things kind of add up when it comes to just logistically coordinating across your entire facility.
Tom, a lot of ORs, in order to help with that efficiency, they'll do flip rooms, right? Where you've got same surgeon, they're going to operate OR 5, OR 6, and they're going to finish up an OR 6 and then flip over to OR 5 and get that case started. So that can sometimes be a complication. And we have a lot of facilities that actually do that every single day and are able to manage that flip room process much smoother, correct?
Yeah, so I mean, again, so one of the big problems that we've seen with flip rooms is the fact that you have to keep everybody busy, right? You have to coordinate, especially if they're inpatients. You have to coordinate not only with the pre-op process, but with transportation. You have to make sure that call for the next patient is done properly. A lot of flip rooms, I don't know why, but they seem to be orthopedic oriented. So you have a lot of positioning issues that you have to do with the patient. And again, all of these things require multiple humans to touch the process and participate in the portion that they're responsible for. So anytime you have anything where you have additional coordination, additional logistics, to have a system that is handling that, to have a system that's looking forward. You know, one of the things we didn't talk about was alerting here. One of the things the system does very, very well is it looks forward a few minutes to, let's say, a half hour to an hour, and it says, geez, you know what? I still don't have the H&P for this case. I still don't have anesthesia that said that they've consulted with the patient. So when those time periods start becoming critical, where you're within this time window of when, if we still don't have that done, the case is a good chance of being delayed, we're going to send out a jeopardy alert. We're going to send an alert to the anesthesiologist or to the anesthesia lead and say, hey, look at this case. We still don't have the indication that the patient and the anesthesiologist have chatted this morning.
Now, Tom, just to be clear, that alert, that's not triggered with someone going and entering information into the computer. You're talking about an automated process where that you kind of eliminate that human interaction that has to remember to go do that, correct?
Yeah, absolutely. I mean, all of these things can be automated now, all these alerts. I'll give you a really simple one that actually happens the night before. The system goes out and it looks at all of the H&Ps. And it says, gee, we still don't have an H&P for these 2 cases. So it actually automatically sends a message to the physician, to the surgeon office, and says, we still don't have H&Ps for your cases tomorrow morning. Now at 5:30 in the morning, if we still don't have them, we send another alert out. And we say, hey, we still don't have the H&P for this case. At 6:30, which is a half an hour before the case is supposed to start, we send the alert actually to the surgeon and say, guess what? Your case isn't going to start on time because we still don't have the H&P for this case. So it gives you an idea of how, instead of sitting there and looking backward in all of these other reporting systems that hospitals have and going, hey, why did this case get delayed? What happening, and going and finger pointing, you're actually looking at the front of the windshield and you're sitting there going, hey, wait a minute. I know that this H&P hasn't been registered yet in the systems because I'm getting all these data feeds in automatically. So why can't I just send an alert out automatically without anyone being involved and say, hey, where's the H&P? And maybe most of the time, in fact, this is proven out historically, most of the time that H&P does show up now.
Yeah.
But it wouldn't have if we didn't send the reminder, because some nurse or clerk or even the surgeon themselves was like, oh, I thought we sent that in. Well, no, you didn't send it in.
So Tom, we have another question that's related to training, basically. So install the system, and how complicated is this to pick up on for people to use? Is it cumbersome? Is it going to overwhelm people?
Yeah, so what's interesting about flight control systems and minute-by-minute coordination in these execution systems is that if you have to do a lot of training on them, you're dead. The system just won't work. So they have to be designed in a manner that they're as simple to use and as simple to understand as, let's say, using an ATM at a bank. If you put a system in place that's supposed to be supporting everyone logistically, and you need to get a surgeon to sit down and be trained on the system and learn the system, it's not going to work. So, and I know this sounds somewhat hard to believe and kind of antithetical, but the reality is these systems have to be transparent. They have to be something that you just glance at a touchscreen board, you glance at your phone, it tells you exactly what's going on with your case. So the system has to adapt to the way you want your information and how you want it, and it has to be something that you don't need to be trained on to take advantage of. And in fact, that's the whole key with all these systems, including air traffic control. You have to get people to want to adopt the system, not force them to adopt the system. This is absolutely key for this. So this has to fit your reality, your frontline staff's reality. It can't be a one-size-fits-all standardization across all of your hospitals in, let's say, your system. It's got to be something that's adaptable and customized for the reality that your frontline staff addresses every morning when they start their shift. And it also has to be something that the frontline staff wants to use because they get immediate benefit from looking at the system. They get immediate benefit from seeing those alerts that come up on their phone. They get immediate benefits from being able to see, oh, look, it looks like we're going to have so many staff that are going to have to be called back this evening at 3 p.m. You know, it's a pull, not a push. It's not management telling everyone, hey, you need to be trained on this system and you have to use this system.
So I think you touched on an important point. Back to our title of the whole webinar today was, you mentioned customization. So again, we're not standardizing. It's not a one size fits all for every hospital. It has to be customized to every single facility that you go into because everyone is different. And then one other point that came in, and maybe a little bit more on the technical side, maybe someone from IT, but in terms of the footprint to install this, or what's involved, is it complicated? How much time? what does it take to kind of get this installed at a particular facility?
Yeah. So the simplicity of the installation process comes from one primary point here. And again, this is going to sound kind of odd because this is such an outlier in terms of IT systems. We are not the system of record for anything clinical, anything from accounting or from regulatory reportings or compliance. So if we're not the system of record, that means we don't have to be responsible for changing anything that is currently happening in the facility, including the other IT systems. If you remember that slide that Luke put up earlier, all of those were inputs into the system. Nothing was going back in the other direction. So this is truly air traffic control. We're not telling the patient, we're not telling the surgeon how to operate on the patient. We're not telling, the EMR what happened in the operation or how many hours needed to be billed or anything to do with regulatory compliance or infection control. So all of those things stay exactly the same the way they're currently being operated in the hospital. And so what you have is you have very little training, and you also have no data going back into your legacy systems. So that means that now all we're looking at is data being fed in one direction into our system in order to allow for all of this logistics to be able to be managed and coordinated. Because of that, typically, because we have almost no training and we have literally no work to do on the interface side, these systems can be implemented in a few months in a hospital. In fact, I think our fastest was actually at a federal government hospital, and I think we did it in 89 days from contract to where we actually went live. And I know this sounds really way different than everybody else's way in which they approach systems, and because there's so much coordination that has to happen when you put other types of systems in place. And in this system, the footprint on this is fairly light compared to what you have with other types of IT projects.
Yep. I think we'll certainly continue to get some questions coming in if you guys still have some additional questions. But we've sort of run to the end of the presentation, and if there's additional questions that want to come in, fine, we'll get those. But otherwise, I think we're about wrapped up here, Claire.
Yeah. Well,
so
let me talk a little bit about the last slide you put up, because I just noticed it, and that is building these teams. One of the things that's really interesting is accountability when you put these systems in place. And the reality is it becomes unavoidable. I mentioned earlier how, a surgeon, that was habitually late ran into one of our hospitals. She looked at the board and she went, "Oh, crap, everyone's waiting for me again." It's so obvious who was on time, who wasn't on time, when was the room cleaned, when were the case cards show up, when did anesthesia have their consult with the patient, when was pre-op finished. All of these things become, when was the patient and to what bay were they rolled into PACU, when was the family informed that the surgeon was waiting for them to do the post-surgical visit. All of these things become obvious, and you can see them right then and there. You don't have to wait for a report next Tuesday to argue over what happened. Everyone sees exactly what's going on this very moment. And what that means now is you get this level of accountability, not just within your own department, but you get this level of accountability across these different silos that had a hard time communicating. Now, all of a sudden, that accountability really turns into a very strong team culture. It doesn't happen overnight. Our observation is it takes about 3 to 6 months for this to start developing across a medical center. But it really is remarkable, the fact that all of a sudden now people are feeling like they're in cooperation with these out of departments. They're not in conflict with them anymore. And that is a huge cultural shift for many of these very large medical centers.
Great. Well, Tom, thanks again for your time. I know this was kind of a redo backed by popular demand, but appreciate the time to kind of go through this again. And I know Becker's will be sharing some additional information about how to reach out if we want more information. But Claire, I think we've kind of come to the end of what we're going to do here.
Yeah, so now sorry, go ahead.
Oh, there was one late question that came in here about a surgeon that came in late. So you just covered that, Tom, I think, in terms of what was the outcome of the surgeon coming in late. So
actually, I have a great story on that one if everybody has a few minutes. So this surgeon, without naming any names or the facility, she was fairly senior, but she had young kids. And the reason why she was habitually late is because she wanted to get her kids off to school every morning. And so, but she was also senior enough that she got the first case of the day in this OR. And so it was just a natural problem. And so she would habitually show up about a half an hour late every morning, very stressed out, very much, doing the thing where she's trying to juggle family and a career and everybody else that's waiting for her when she shows up. After about 3 to 4 months, she started realizing that the second case of the day was going off on time 98% of the time. So she came to the OR director, and we were involved in the meeting, and she said, look, I want to change my block from the first case of the day to the second case of the day. And that was, instead of starting at 7 a.m., she was going to start at around 8:45 in the morning. She said it was the best thing that ever happened to her career. So all of a sudden, she was in a position where she knew with confidence, because of the system and because cases were getting off on time, that she could start at 8:45 in the morning. She could get her kids off. She could come in, have a cup of coffee, talk to people, relax, and not be the person that people constantly looked at and said, "Ooh, you're half an hour late."
Yeah.
So this just gives you an idea. And again, this is just one vignette. I definitely don't want to try to make this sound like it's going to happen everywhere, but it does give you this idea that now you're no longer looking at these things as individual problems and point processes. You're really looking at them in terms of a team being developed.
Yeah.
And so that, to me, that's actually a great question that person brought up. What happened in that? And we had the same situation.
Well, there was an orthopedic. Yeah, orthopedic surgeon that I know said that after about 8 months of using the system, things were running so much more efficiently. He was able to actually do an additional knee at the end of the day. And he said, I would never do that before because I would not make it home for dinner. There's no way. But he had the confidence to add that additional procedure on and still get it done in the appropriate time, and was very pleased. So that was good, obviously, for the hospital, good for the patients, good for him. So again, sort of at the other end of the spectrum toward the end of the day. But,
yeah, I mean, the 500-pound gorilla in terms of the financial business case for these types of systems are that you end up with more cases being done during prime time. You end up with less overtime, and you end up with clinical staff that actually can spend more time with the patient than they did before, because they're not constantly trying to figure out what's going on. They're not on the phone. They're not being redirected and then find out that something doesn't make sense or that one of their colleagues wasn't informed of something. So really the coordination aspect here is key to just making things more efficient. And it won't come from improving your EMR or getting another consultant to come in and try to figure out how to improve your best practices. This really is a coordination issue. It's an execution tool that helps that frontline staff that really doesn't have the ability to affect change, especially across out of departments.
Yeah. Excellent. Okay. Claire, I think that is an opportunity to wrap up and let everyone get back to work.
Excellent. Yes. I would just like to thank you all for joining us today in such a great presentation. Thank you, Luke and Tom, for an excellent presentation, and Healthcare Control Systems for sponsoring our webinar today. To learn more about the content presented, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you again, everyone, for joining us today, and have a great rest of your afternoon.
Thank you.
Thank you, Claire.